Ananda Pushpakumara.
Good afternoon. I'd like to welcome all of you all to a very interesting symposium, which I'm sure you will all enjoy since it's on interventional cardiology. And I would like to invite our first speaker. We have had a small change in the schedule, so there will be only 3 lectures today. Dr. T.S. Clare will be speaking to us on the role of rotablation in complex coronary intervention.
Well, first of all, I thank the Sri Lankan Cardiac Society to invite me. Of course, this is not my first time. I've been here before. It was a pleasure to visit Sri Lanka, which I always found very disciplined, clean country as compared to my own country. People are very respectful. I enjoyed always coming to Sri Lanka. Well, coming to the question of complex angioplasty and role of rotablation, I would think if there's a very important milestone in the development of interventional cardiology, after balloon angioplasty and stent, the third one I will consider is rotablation. It is a very, very important technology to deal with the very difficult cases. Coronary artery calcification is an indicator of advanced coronary artery disease, and the extent of calcification strongly correlates with the degree of atherosclerosis. Of course, PCI is in these kind of lesions is associated with the lower success rates, higher complications, and worse long-term outcomes compared with the non-calcified lesions. Of course, we assess the calcification. We grade them severe calcification when it is seen without even cardiac motion, and roughly 6% of the people will have a severe calcification on the coronaries. Moderate calcification is only when there is a cardiac cycle before the contrast injection. Something like 30% will have moderate calcification in the subset of PCA patients. Visible calcification on angiography predicts a large arc of calcification on the IVUS. Complications in calcified lesions, unsuccessful PCI. We have seen, we see frequently people in the peripheral hospitals try to do angioplasty. They fail to cross or fail to dilate the lesions. So unsuccessful cases are high. Balloon ruptures, dissection, perforation rupture, asymmetric malopposed and underexpanded stents, higher incidence of restenosis and TVR, higher incidence of peri-procedural myocardial infarction, and higher incidence of stent thrombosis. Well, the rotablation was developed by Dr. David Oth, and later on it was popularized by Ritchie and his colleagues. Initially, roughly 10% of the patients were rotablation in at least major cardiac centers, but now overall 3 to 5% of the cases are being done with rotablation in good volume centers, and obviously less than 10% in other centers. Cardinal indication of rotablation remains calcific arteries. The current PCI guidelines state rotablation is a reasonable fibrotic or heavily calcified lesion which might not be crossed by a balloon or adequately dilated before stent implantation. This is class 2 indication, level of evidence is C. Other indications are that if you have a chronic total occlusion, you are not able to pass the balloon. Osteal lesions, bifurcations which may be associated with both bulky plaque and vessel geometry, unfavorable stent deployment. There has been use of in stent restenosis, especially where there is a lot of new intimal hyperplasia. For new intimal hyperplasia and stent restenosis, it is advised only as a second choice in select cases, but certainly rotablation is also helpful when lesion cannot be crossed with the balloon. When multiple jails, you have multiple jailed branches, there also rotablation may help to prevent snow flow into these branches before the balloon dilatation. In cases where the metallic stent struts contribute directly to lumen obstruction, rotablation may be utilized for stent ablation. But here, I would say this stent ablation should be done only by experienced operators, not with everybody. There's a lot of data available, the recent rotablation studies, and if you see the TVR in various of these studies are something like 5% to even 23 or 25% of the patients. This is a study which was published, multi-center trial, rotablation before Texas implantation. Acute gain was certainly higher in the rotablation group, but however, the late lumen loss in the rotablation plus DES was significantly higher than the DES, and there was a 12.5% crossover rate from DES alone to rotablation. So in general, if you don't have calcification, rotablation perhaps doesn't improve the long-term outcome, as this study has shown us. So this is the way we do the algorithm. Angiographic calcification, if it's mild, go ahead and do your angioplasty the standard way. If it is moderate, then best would be to do an IVUS or an OCT and define how much is the calcification. If you still think on the IVUS it's not too much, you can do the non-atherectomy strategy. If you think it is significant, then you go to the rotablation. If there is severe, you just go to rotablation. My own thinking and philosophy is that whenever you have a patient, you have taken the pictures, if you think, should I do rota or should I not do the rota, best is to do the rota in that situation. It's my gut feeling that rather than repenting later on, it's better to start rotablation right away. Now, important issues and doing rotablation, you should consider if the ejection fraction is low, if you have very long lesion, a very acute bend, should only be carried out at hospital where there is emergency bypass surgery available. Saphenous vein graft in general is a contraindication. Unless very, very rarely you may have a bad osteal stenosis, which perhaps you may use rota, but in the body of the vein graft, perhaps it is useless and it will produce more complications and embolism. If it's a last remaining vessel, because if you get no flow, you may be in problem. If there is a lot of thrombus, if there is significant dissection or non-surgical candidates. In acute myocardial infarction, generally we would like to avoid rotablation unless you are stuck up in a patient where the lesion is very difficult to dilate. One can use it, it is not an absolute contraindication. Well, this I think all of you know the structure of the rotablation, and you need the cylinder, either oxygen or nitrogen to run the device, and we can, I think. Now, the thing is, the burr will cut inelastic tissue, calcium fibrous material, while sparing the elastic tissue. Therefore, burr may be somewhat ineffective in soft lesions, and in case of guide wire wires, where the wire is not centered, the wire may press on the lesion and on the soft area of the artery, and it may convert elastic tissue to inelastic. So cutting can occur in that situation when there is a wires. Coaxiality of the guiding is very, very important rather than the support. Orientation of the guide will determine orientation of the wire, so it is very important. Well, now even some of the 6 French guiders can accommodate 1.75 bird. But I think it is always better to select a rather 1 French higher guide. That's my experience. You are more comfortable. If I have to use 1.75, I'll use 7 French at least. I will not use 6 French. Guide wire tips, position the tip of guide wire distal to the lesion. If unsuccessful or complex anatomy is present, when this wire is very unfriendly to cross. So you can cross with a routine wire or a BMW or some other wire and then change it over the some exchange catheter, and don't run bird very close to the spring tip. Do not pull the guide wire to straighten the loops. Do not operate system with bends or kinks in the wire. Better is to change it. Do not operate system if guide wire spring tip is prolapsed into the branches. Burr size, keep it simple. In almost all cases, the rotational atherectomy is being used for lesion modification. We don't want to use 80 or 90% of the vessel diameter. Most of the patients, we would be happy to use 1.5. But if the lesion is very tight or very long lesion, then it's better to start with 1.25 and then upgrade 0.25 in these patients. Lock the burr positioning, lock the advancer knob 2 to 3 centimeter forward before advancing the burr into the guiding catheter. Of course, you have to advance the burr over holding the wire. Best is to single operator. It's very difficult to coordinate between two, so the operator holds the wire left side and with the right hand you push the burr forward. When the burr is proximal to lesion, relieve any forward tension on the drive shaft by unlocking advancer knob and pulling it back. It's very important. Otherwise, if there's a tension in the shaft, when you start rotablation, it will jump into the lesion and you can have it can stall there. Burr speed, if it is 1.25 to 2, then 160 to 180,000. If the large burr, it is a little less than these things. Gentle packing motion, maintain the revolution within 5,000. If the drop should not be more than 5,000, limit runs to less than 30 seconds. Total rotational procedure time should be less than 5 minutes. Upsize the burr if necessary in 0.25 increments. Inject contrast in between to see the distal vessel and pay more attention to the downstream rather than the lesion. Finish with the 1 or 2 polishing runs. When you give polishing run, there should not be any resistance, there should not be any drop of the revolution. That means you have done a good rotablation. About the bi-connector adapter, see, you should not close it tightly, otherwise it will damage the system. It should be good enough just to prevent too much of bleeding. In fact, let there be little bit bleeding rather than making it tight. The hemostasis valve should be closed just tight enough so that the blood loss doesn't happen. And otherwise, you can damage the system. Fine details, gradual intermittent ablation with a packing motion has to be done to minimize the deceleration and thermal injury. During ablation, operator should be attentive to potential warning risks such as visual lack of smooth advancement under fluoroscopy, auditory, if there is certain change in the auditory noise, pitch changes, and then the tactile resistance if in advancing the knob. The fundamental is never use force. Go slowly, pack it, come back, so that there is no significant decrease in the revolutions. Well, important complications are slow flow, no flow. It is always better to prevent slow flow or no flow. When I say prevent, give adequate amount of nitroglycerin, calcium channel blockers before you start the rotablation. And intermittently also you may have to use this combination and avoid hypotension. Give good amount of fluids to these patients, let the saline run, and in case of any hemodynamic borderline situation, use an intra-aortic balloon pump, and you can have dissections, you can have a lodged burr and perforation. These are the complications. Now, one of the most important things is the stuck burr. This is the most important complication and difficult. Well, the simplest method is to retrieve the untrapped burr by pulling back to the rotablator system manually, but this doesn't work always. If it doesn't work, then you recross with another wire, the routine wire, either a hydrophilic wire or the BMW wire, and go distal to the burr. dilate with a small balloon, 2 millimeter balloon, it will release it will relieve the stuck of wire, and then you can pull it back. And this is what is shown, this, that you would go with another wire. When you have to use another wire, there are two ways to do it. One is that if you have a large guider, you can go through the same guider. But if you're using 6 French particularly, then you may not have enough space to go with other devices. Then you may use a different guide. So that's another way, another reason that bigger guider use is a little bit better than you going to for a smaller bird. The other thing you can do is that, this is described by Dr. Sakura, that you cut the burr, like you are cutting the burr. I don't know, this is not working. So cut the burr, and when you cut everything, that means you are cutting the sheath, you are cutting the shaft and cutting the rota wire. Then you can pull back the sheath, it will come easily, then you have a space to go with another wire in the same guider. So this is one of the ways to create more space in that. You may have to use snare sometimes, it certainly needs 7 French. Cut the proximal end of the rotablator and rota wire and advance a snare over the shaft down to close to the lesion, and simultaneous traction on the snare and the shaft down close to the lesion. This reduces the risk of traumatizing coronary vessels. Another thing which can help is the deep catheter intubation. So you can take your guide up to where the burr is stalled, and then it's a little bit easier to bring it back. One thing you should remember, that this wire will not come out of the burr, because there is a distal little bit, there is a point which is bigger than the hole in the burr. So that thing is at least is good, that the wire will not come, it will remain inside the vessel. So then you can use simultaneous traction on the burr, shaft, and counter traction on the intubated catheter. The catheter tip can act as a wedge between the burr and the surrounding plaque, which makes exert a larger and a more direct pull and retrieve the burr. Facilitated by cutting off the system and introducing a second smaller guide wire or extension catheter over the drive shaft is another way. Well, if nothing works, then I think you have to request your colleagues in the surgical department. That's the last way. This is the algorithm. I think we have practically discussed how to deal with. This is very important actually, stuck burr, how to deal with that. First of all, we should avoid stucking the burr by going as low as possible. If it gets stuck, then we should know how to get it out. Well, there is something called orbital atherectomy, which is a recent thing. I personally am not greatly fond of orbital atherectomy, but patients who have moderate calcification, one can perhaps use this technology. But whenever the calcification is significant, I think it's best to go rotablation. There's no real as good technique to deal with the calcified vessels as rotablation. I think we can leave. I will just show you one case. This was a very, very interesting patient. Had a bypass surgery done, I think, in 1997. He again had repeat angina and angiogram in 2017, early January or so, showed all the grafts were occluded, and he was repeat bypass surgery was done. After 2 months or so, he started again having class 3, rather class 4 angina, and ejection fraction was normal. And this is the situation. That means practically normal ejection fraction, no graft on the left side. This graft is to the PLB, very small branch actually. The PD was okay, but this graft is supplying very small PLB, and the graft is also diseased, practically not much help. So this patient was refused intervention at various places, and because of very severe angina, not responding to medication. So we had to take this for, if you see, the left main is diseased from the ostium, calcified, LAD is also calcified, and there is a bad bifurcation distally, which is also diseased. So the only way to do this, it should be working, it should be moving. Okay, right, another pictures. This is a GL catheter, guiding catheter. And this is the I first passed the BMW wire into the LED, but even a 2 millimeter balloon will not go. It will push the guiding catheter out. So it was very clear actually that one has to use rotablation in this patient. So rotawire was passed into from the left main to the LED, and we used the 1.5 burr, and right from the ostium to the lesion in the LED, that the whole thing was rotablated. Then balloon dilatations at various places. So that's the result after balloon dilatation and rotablation. If you note here that there is a very sharp angle of the circumflex as usual in many patients, then another wire is passed into the circumflex. Here it is, and it was dilated with balloon. Fortunately, circumflex didn't have that much of calcification, so did a rotablation, did a balloon dilatation of the circumflex. And I thought best would be to put a stent from left main to the circumflex first, because it is much more difficult than going into the LED. LED is much more straighter, and then it was a 2.75 into 32 synergies. This will not go, the stent will not cross at all. Then I use the Guidezilla to cross it, and now see the left picture. It was very nice to see that though the guiding catheter is practically out of the left main ostium, but because of Guidezilla, you could cross this very long stent into the circumflex. So this was deployed. Then we did the pod with 3.5 into 8 millimeter balloon. Then we crossed into the LED and opened the struts. Then I did a tap into the LED and another stent. This was a resolute integrity 2.5. This is small vessel, some or the other, and deployed that. Then the kissing. It is a practically must to do kissing in these patients. So that was the result. Now you can see that there is a ostial miss. It was very clear from the beginning that the circumflex stent which we put into the left main, it was not occurring in the ostium, so another stent was put 8 millimeter into that area, and that's the final result, which I think is very acceptable. This patient, after about 7 months of this angioplasty, did complain of some symptoms, and we repeated his angiogram. It was very nice to see that the vessels were all flowing without any significant disease. So, my dear friends, if I have to conclude that rotablation is a time-tested with good immediate results. However, evidence is yet to demonstrate that routine rotablation before DES reduces stenosis practice does not. It is possible that the impact of rotablation on repeat revascularization is most pronounced for a subset of heavily calcified lesions. IVUS or OCT may prove useful in identifying features of plaque morphology predictive of benefit. For those people and those centers who do not have IVUS or OCT, I would think they should be a little more liberal in using rotablation rather than getting caught with a balloon dilatation and then producing a difficult situation. Thank you very much for your kind attention.
Thank you, Dr. Priya, for the excellent presentation. And then may I call upon our next speaker, Dr. Asis Haman, to talk us on TAVI.
Okay, thank you. So I was asked to give this talk on TAVIs, and what I thought I would do is tell you about our program, which has been running now for 10 years. We started in 2008. I'm aware that Sri Lanka hasn't started a TAVI program yet, but is in the process of looking at starting. And there are many advantages, of course, of starting late, is because you can learn from the mistakes that we made. And what I hope this talk will do is show you the evolution of the program in Newcastle. So this is where we were in 2013. So after 5 years, we were still giving general anesthesia. We were using multiple imaging modalities, so patients were being assessed by CT. The patients were having a T transesophageal echocardiogram, and then a transesophageal echocardiogram would be present in theatre as well. Patients would either have a right femoral artery cut down. I'm just going to tell you about the femoral program rather than the transapical or the transaortic. And they would then be transferred to the intensive care unit, and the mean stay for the 5 years was 4 days. 2 years after that, and what we are doing today, so in 2015, we switched to local anesthesia, single imaging modality, so now we just have a CT to assess the valve size, assess calcification, assess peripheral access. We now have a closed right femoral artery puncture using a closure device such as PERCLOSE or STARCLOSE. Patients are transferred, because they're under local anesthesia, they're transferred to our general cardiology ward. The mean in 2015 day stay was 2 days. It is now less than 2 days, and around 40% of our patients are going home the next day. So what is it about aortic stenosis? You'll know this. So the patients that we are selecting initially were those at high risk. So aortic stenosis has a very, very poor prognosis once the patient presents with symptoms of either angina, syncope, or heart failure. And you can see on the right of this that if they present with heart failure, the average survival from initial presentation is 2 years. With syncope, it's just over 2 years, and if they develop angina, it's just over 4 years. So survival overall after the onset of symptoms with severe aortic stenosis is 50% at 2 years and 20% at 5 years. And it's well established, we don't need to go through this, that the only treatment hitherto was surgical replacement. There are no pharmacological treatments, and prior to TAVR, there was no percutaneous therapy either. So surgery was and remains a great solution for severe aortic stenosis with symptoms. However, it was quite clear that when you looked at registries of patients referred for surgery with severe aortic stenosis and symptoms, that just under 32% of patients were deemed to be high risk or inoperable for surgery. And that was because of comorbidities. So in developed countries, aortic stenosis is a disease of the elderly. It is a degenerative disease associated with heavy calcification, and around 90% of our workload is in patients over the age of 80. A very small percentage of patients, around 5 to 10, have bicuspid aortic valves, and they undergo surgical valve replacement in their late 50s and 60s. So TAVRs, initially, when we started, was restricted to elderly patients who were inoperable or at very high risk for surgical AVR. So this was the first study. The partner study was seminal studies of this procedure in these patients. It's now old data, but essentially what it showed was that if you looked at patients with severe aortic stenosis and compared those who underwent transcatheter aortic valve implantation in the blue line here and compared those to standard therapy, i.e. no surgery because they were inoperable, you saw that at 2 years there was a significant reduction in mortality, as you would expect, because these patients were having a bioprosthetic valve introduced in a less invasive manner than surgical AVR. And this study, the partner study, really revolutionized and gave a stimulus for this program initially in Europe and now latterly in the States and other countries. So what have been the learning points that Sri Lanka can use when it starts its program? So there are 3 things. The patient profile is hugely important, and for us, coronary interventionists, it's been a huge learning program, because we have now become specialists in care of the elderly. Previously, the mean age of patients undergoing PCI in the United Kingdom is 64, and it's remained at 64 for the last 15 to 18 years. The mean age of patients undergoing TAVI is 84. So this was a patient population that we as a group of physicians were not used to treating. They had comorbidities, they were frail, some of them had early signs of dementia. So we have learned as a group how to deal with these patients better, not just in our communication skills, but also in our way that we gain access, the heavy calcification, not of course just in the aortic valve, but in the femoral arteries. We've learnt a lot about imaging. As I said before we would have CT, we would have TEE, and we would have transthoracic on standby in theatre. Now we just have CT imaging. We don't have any form of imaging in the cardiac catheter laboratory now when we do the procedures, beyond using an ultrasound probe to identify and puncture the femoral artery and the femoral vein. And of course, we've learnt a lot about the procedure. As I said, the mean age of our patients undergoing this procedure is 84. They are frail, and the severity of the aortic stenosis has developed over a relatively short time scale. The key to a successful procedure, the majority, certainly not all of our patients, have been independent prior to development of their first symptoms. Because they're elderly, they have comorbidities. In Britain, the majority of these patients will have chronic obstructive pulmonary disease. So we have to make sure that their symptoms of breathlessness typically is due to the severe aortic stenosis and not other comorbidities, heart failure, COPD, and the like. And sometimes that can be a challenge. So, this is repeating. So what is the role for esophageal echocardiogram? So before, when we started the program, we would use this to size the aortic sinus, the left ventricular outflow tract diameter, and essentially to size the valve. And when we first started, we had a choice of 23 millimeter or 26 millimeter sapien valves. But it became very clear that CT was not only less invasive, it actually gave more accurate information about the aortic root, the aortic valve, the aortic sinus, and we were able to measure very accurately the size of the valve required. Initially, we were also dilating the valve prior to inserting a TAVI valve. So we would perform balloon aortic valvuloplasty, and that was the standard teaching. And without predilation was not accepted. But after about 5 years, there were reports of centers, particularly in France and Germany, that were directly stenting the aortic valve. And so that is where we are now. We don't do balloon aortic valvuloplasty because there are reports of the more you interfere with the valve with a balloon, the higher the risk of an embolic stroke. So femoral access, surgical cut down or a blind puncture with percutaneous closure. So surgical cut down was recommended initially, but now there have been randomized studies of closure devices such as a per-close versus surgical closure. And now that the technology has moved on, and this is another advantage of starting late, when we first started, these devices were 26 and 24 French. They're now down to 18 and 14 French devices. And in these randomized control studies, the closure devices gave as good a result as surgical closure. So the per-close gives you security in devices ranging from 5 French to 21 French femoral artery access. And for sheath sizes greater than 8 French, we use 2 per-close devices. It's a simplified knot delivery with a pre-tied knot, and in the majority of cases, it works very well, and you get secure hemostasis with 2 devices. Sometimes you need to use an angioseal as well, but in the closure devices, the closure is not clot dependent. So it is mandatory, almost I think mandatory, and I think I'm correct in saying this, that when you puncture the femoral artery, it has to be at the right point. If it's too high, it goes beyond the inguinal ligament, and it's very difficult because the femoral artery dips down into the pelvic cavity. It's very difficult to then close it using a closure device. You mustn't puncture the superficial femoral artery, which is smaller, so there is a narrow 3 to 4 centimeter area where you should puncture the common femoral artery. And we always use, and we recommend that you use ultrasound guidance to puncture the artery. Do you need a second femoral artery puncture? When we first started, we would puncture both the right and the left femoral artery, the other femoral artery for pressure guidance. Now we use the right radial artery for our pigtail, and we only puncture one femoral artery and one femoral vein for the temporary pacing wire. So, in 10 years, TAVI has evolved to be an effective and safer procedure. A lot of that is the learning curve, but a lot of that is through technological advancements, with the devices becoming safer, sleeker, and smaller. As I said, when we started, it was 22 to 24 French, and it's now down to 14 and 18 French. Importantly, the procedure itself for individuals, interventionists doing percutaneous coronary intervention, the procedure itself is relatively simple, and I say that advisedly, and I say that with caution. The great learning curve for us has been in the type of patients that we have been and we have had to deal with, which is an elderly, frail patient population with additional comorbidities. Permanent pacemakers. I can't leave a talk on TAVIs without talking about permanent pacemakers, and this is really what's stopping us from sending patients home the same day. So there is undoubted increase in the use of permanent pacemakers after the TAVI procedure, and that's simply because of where the device sits, and as you expand it, it can impact on the conduction system. So with the Edwards device, the rate of permanent pacemakers is just under 10%. With the Medtronic device, it's been slightly higher at over 25%. But now we're deploying the Medtronic device slightly higher, and we now have figures of around 12%, so half this figure. But there is a rate of atrial fibrillation also, and it is for this reason that we choose to keep our patients overnight, telemeter them overnight, and if there are no changes on a 12-lead ECG the following day, no arrhythmias, we then send them home. So we have now moved from high-risk and inoperable patients to the talk now is about intermediate and low-risk patients. The issue has been the durability of these bioprosthetic valves. The data now goes to 5 years, but if you're going to look at intermediate risk, these are younger patients who have maybe 15, 20 years of life, and where surgical valves have a very long tradition of good, effective treatment for aortic stenosis. So if you look at this curve, you had patients right at the extreme, which were even too high risk for TAVI. The bulk of the studies, the original studies, the US core valve and the partner studies, looked at inoperable and high-risk patients, the data that I've just presented. SIR-TAVI and Partner 2 is going to look at intermediate risk, and the NOTION study looked at low-risk patients. In the intermediate risk, these studies showed that it was associated with low stroke risk, and that is very important. If you're going to look at intermediate risk patients, you must not give them a stroke. You have to be knowledgeable and confident in the durability of the bioprosthetic valve in the TAVI valve. You have to worry about new onset atrial fibrillation, paravalvular leak, and of course it has to have low pacemaker rates. You don't want to be giving your 65-year-olds permanent pacemakers. So how might these bioprosthetic valves be in terms of their durability? So if you look at the progress of the use of bioprosthetic valves in surgical AVR, it may help to give us some signal. If you look at this study is really important. It was published just 2 years ago and looks at patients receiving bioprosthetic valves. So these are in the light color, the gray color, and the metallic valve is in the darker color. So if you look to the left, you see that the mean age of patients receiving these valves has reduced from 68 to 61. And you can see the reason for that is as time has moved on to the graph on the right, more and more surgeons have felt more comfortable in treating more patients with the bioprosthetic surgical valve. And what that tells us is that the technology of the bioprosthetic valve, treating them with chemicals that prevent early calcification, has led to these bioprosthetic valves in the aortic area having longer durability, and we now have more confidence that these valves are more durable and they're being implanted in a younger patient population. So what are the remaining challenges for durability? One is pacing rate, as I've said. One is heavy calcification, and we are now looking at decalcification technologies to coat the valve with. Which specialist should be part of the TAVI team? When we started, we had a surgeon, we had an anesthetist, we had a transesophageal echocardiographer, we had 2 interventional cardiologists, we had 2 nurses, we had an anesthetic nurse, we had a theatre nurse. It was hugely expensive to perform TAVIs. That was in addition to the cost of the valve. Now we have the same team that delivers a PCI. So in the UK, typically that will be a radiographer, 1 floor nurse, 1 assistant, and that's it. It's done under local anesthesia and with 1 nurse preparing the valve. We've moved on from high risk to now doing low and intermediate risk patients, particularly those who've had previous coronary artery bypass graft surgery. The surgeons don't want to perform redo procedures, patients with porcelain aorta. So we've moved into the intermediate and lower risk patients. So how can we make it pay? And for any healthcare system, whether it's Sri Lanka, whether it's the UK, you have to make it pay. By reducing the numbers of specialists required for this procedure, we have made it a more efficient and more cost-effective procedure. Thank you for your attention.
We'd like to thank you, Professor Zaman, for that very comprehensive and interesting lecture. And we also like to thank you very much for keeping to time, as we are a little bit behind schedule. So in interest of time, I think we'll move on to the next lecture. I'd like to once again invite Dr. T.S. Clare, who will be speaking to us on the left main bifurcation.
Well, left main, by and large, was supposed to be contraindication for PCI, but now more and more people have started doing left main angioplasty. But I think still, according to the guidelines, surgery remains number 1 option in left main disease. About 5% of the patients undergoing coronary angiogram, they have a significant left main disease. Left main disease usually indicates extensive coronary artery disease. Usually there are also distal lesions in the different vessels. The left main subtends a large amount of myocardium, almost 70 to 80% of the myocardium, and may be associated with ventricular dysfunction, arrhythmias, hemodynamic compromise, making it potentially a very lethal condition. Percutaneous coronary intervention can be a safe and effective method for revascularization in many patients with left main disease, not in all, but many patients. If you see the diagram on the bottom, most of the left main are bifurcation lesions, almost like a 73–74%. If you have an ostial and body left main disease, it's very, very simple, and I think there's no question that ostial left main and body left main is much better than doing surgery and with very good results. So the special thing in left main are that the side branch is, which is usually circumflex, and it has a large reference diameter and is angulated. A highly angulated circumflex takeoff may impact on prognosis after left main stenting. Left main is the only bifurcation where the proximal main branch originates directly from the aorta. This increases complexity because of the interaction of the guiding catheter with the stent, which increases the risk of stent longitudinal compression. Proximal reference diameter may sometimes be very large, more than 5 millimeters, which is close to the dilatation limit of many stents available, coronary stents available. Left main trifurcations are encountered in about 10% of the left main disease, and that may pose an additional challenge and may require specific more strategies. Guiding catheter, in elective double stenting, we have to use a large guiding catheter. By and large, most of the times it is the Judkins guiding catheter which is good for left main, because the implants and others, they tend to get inside and they may distort the left main stent. Strategy will differ according to the anatomy, bifurcation lesion angles, relative difference in the vessel size. Different bifurcation techniques are used, either tap, culotte, or crush or double crush. Passage of stents around the tortuous circumflex can be challenging. Ensuring that ostium is covered without an excessive length of stent protruding into the aorta is important. Usually one would like maybe just one strut outside the ostium. Otherwise, doing a repeat intervention in these patients may be a challenge. Crossover stenting, that means from the left main to the LAD, is preferred when there is no significant disease in the ostium. Now, angle is very important because metal fatigue with an acute angle predisposes to strut fracture, and areas of low shear stress promotes restenosis. A wide angle between the left main and the LAD is associated with a reduced event rate after stenting because of less frequent TLR. In double crush study, the so-called DK crush 3 study, double kissing crush was associated with a lower rates of major reverse cardiac events for the left main branch when the bifurcation angle between the LAD and the circumflex was more than 70 degrees if you compare with the culotte technique. If the bifurcation angle is less than 70, either the culotte or the double crush technique can be performed in these patients. Well, we have to prepare the lesion very well. Coronary calcification is a potential common in left main, and it is likely that adjunctive plaque modification will be required to facilitate optimal stent implantation. If you feel there is a calcification, it is a good idea to do the root ablation. When plaque modification is felt to be unnecessary, either invasive imaging or careful pre-dilatation with an appropriate large balloon is recommended to ensure that subsequent stent expansion is possible. Well, left main is another intervention where there is, I think, very significant role of imaging, either by IBIS or OCT. You can study the anatomy very well, study the calcification and the angles by doing an imaging before you start doing the procedure. That will also help you to decide whether you need root ablation or cutting balloon in some of these patients. Now, choosing what kind of treatment you want to give preference for the provisional one stent approach. If the circumflex is small, less than 2.5 millimeter, no or insignificant disease in the ostium of the circumflex. If the osteal lesion is very small, less than 5 millimeters, and if the circumflex is diminutive, right is very dominant, there is a very good angle between the LAD and the circumflex. If there is no significant circumflex disease by IVS, that means the minimal lesion area more than 4 millimeters, and those are the patients where you can use a single stent strategy. Well, it is encouraging to note that more than 80% of the left main bifurcation lesion can be treated with a single stent, which is much simpler, and the results are very good. When you have situation where two stent technique has to be used, when there is a circumflex osteal disease long, more than 5 millimeters, complex lesion in the circumflex ostium, circumflex is large in diameter, disease is a left dominant system, RC is small, if there is a narrow angle between the LAD and the circumflex, and if there is very significant disease of the circumflex ostium by IVUS. These are the patients where you should go with a pre-planned double stent technique. Poor result after provisional stenting. If the stenosis in the side branch, you leave it more than 75%. If the TIMI flow is reduced, if the dissection, if the ostial circumflex with the minimal lesion area is less than 4 square millimeters after the stent. Well, this is the strategy. Left main bifurcation, you should do the IVUS, and no or minimal circumflex disease. Dominator circumflex provisional stenting is advised. You just stent the main, the left main to the LED, and use IVUS for optimization. If you see angiograph jailed side branch, there is nothing. That end of the procedure, if there is a problem with the side branch, you see there is a pinching. It's better to measure the FFR. If FFR is good, then don't touch them, finish the procedure. If the FFR is less than 0.8, then you have to do a kissing. And after the kissing, measure the FFR again. If you are happy, fine. Otherwise, you may have to stent. And ultimately, you should optimize with the IVUS. True bifurcation or two stent technique, bifurcation angle. If it is more than 75, you can use tap or a modified T-crush. If it is less than 75, it is better to use kilowatt or a double decay methodology. And ultimately, again, please optimize with the IVUS, then only finish the procedure. Bifurcation lesion with the extreme atherosclerotic involvement with both the branches. No risk of losing side branch. Again, left main stenting, main branch stenting followed by planned side branch implantation by either tap or by culotte method. Major concern regarding the side branch after, if you have that kind of situation, then either you DK crush or you use a clot from the beginning. Now, if you divide, a simple lesion can change into complex lesion with the presence of two of the following 6 minor criteria. Moderate to severe calcification, then it becomes a complicated issue. Multiple lesions, LED circumflex bifurcation, if it's less than 70, main vessel, reference vessel diameter less than 2.5, thrombus containing lesion, main vessel lesion more than 25 millimeters. Complex lesion generally require a 2-stent strategy in these patients. 1 or 2 stent in the left main, this is some comparison available. And if you see the TLR is much less if you use 1 stent, 5.6 versus 24.2, p-value being very significant. Stent thrombosis is less. The early stent thrombosis, late stent thrombosis, everything is less if you use a single stent. All-cause mortality, death, again, it is less, though the p-value is not significant, but it is less with the single stent. Cardiac death, again, less with a single stent, myocardial infarction. So everything looks much better with a single stent than with the double stent. So use double stent only when you think it is certainly required. Well, these are some of the ways to do the provisional stenting. Important considerations: oversized stent increases the risk of distal dissection and the carina being shifted. Port allows strut of protrusion into the side branch with a larger opening, limits the cranial shifting, corrects malposition, and reduces the ellipticality of the stented segment. So kissing balloon, routine kissing balloon do not provide clear clinical benefit in some of the situations. I think this is the double crush technique. You deploy the stent in the side branch, keeping one balloon into the main branch, crush it, then recross, and then stent in the main branch, and recross again into the side branch, and do a second crush. The advantage of double crush is that it is much easier usually to enter into the side branch if you do a double crush, because it opens the struts of the vessel very well. So it is a little bit better than a simple crush. Tap is easy, and anticipated pitfall of this technique is that a single layer new carina is created by the side branch stent struts protruding into the left main at the level of the carina. The side branch takeoff angle and the site of strut crossing are major detriment of new carina length. So these are some of the things which one has to consider. Frequently used two stent technologies are either a T-tap or a two-culotte stenting and a double kissing decrush. Some of the people, like I think Dr. Samin Sharma from New York, he advocated in some of the patients the two kissing stents. But I am not very fond of this method, because if you use two kissing stents, when the left main is large, if you produce proximal dissection, then it's very difficult to handle these patients, and getting back to these vessels sometimes is a problem. So imaging in left main bifurcation, angiographic assessment of the left main has several limitations. So one should have a low threshold for the use of intravascular imaging. Intravascular imaging can visualize plaque distribution, tissue characterization, arc of calcification, and severity of stenosis. Stent malapposition, distortion of stents during rewiring, and catheter guide manipulation in the left main, as well as stent undersizing, contribute to the long-term risk of stent thrombosis, which is potentially catastrophic in the left main. So it is strongly recommended to have access to intravascular imaging modality during PCI. It is not enough only to have IPAS, it is also important to have expertise in interpretation. Everybody is not expert. Every interventional cardiologist doesn't know how to interpret the IVUS. So it is better to train one person in your lab who is very good in imaging. So call him and let him see the situation. It is mean stent areas assessed by IVUS of 8.2 millimeters square in the body and of the left main, 7.2 at the bifurcation, 6.3 in the proximal LAD, and 5 millimeter in the proximal circumflex are associated with better outcomes. These figures are important to remember. An ostial circumflex mean stent area less than 4 millimeters square confers increased thrombotic and restenotic rates. So here is a study to demonstrate that if you see the cumulative mortality where imaging was used versus no imaging was used, there is a clear advantage of imaging in these patients. This is the European bifurcation coronary tooth study. All patients were randomized into provisional T-stent and culotte, and the conclusion was that when treating complex coronary bifurcation lesion with large stenosed side branch, there is no difference between a provisional T-stent strategy and a systematic two-stent culotte strategy if a composite endpoint of death, myocardial infarction, and target vessel revascularization at 12 months is considered. FFR in the left main coronary disease, it may be used to determine the indication for left main treatment. FFR may be used for safe deferral of circumflex treatment if measured after stenting across the circumflex ostium. I think the second point perhaps is more useful. I really don't know that how much is the value of FFR in the left main stenosis to decide the intervention. Maybe in the left main it is the IVUS which is more important than the FFR. But the side branch FFR, after you see some kind of pinching, if the FFR is good, more than 0.8, you can leave these patients and no further intervention is required. If the FFR is less, then you need to treat these patients. Coming to the hemodynamic support, whether you need it or not, well, it's certain set of, most of the patients you don't need it. But if you have a low ejection fraction, disease and dominant RCA or non-dominant small RCA, maybe in patients needing debulking by root ablation, Impella device is currently recommended for high-risk left main patients with depressed ejection fraction less than 35%. Our philosophy is we don't use prophylactic intra-aortic balloon pump. We have a artery and vein on the right side, a 5 French artery site on the other side. We have the arterial access. In case we think there is a need, we can go in very fast. Prophylactic intra-aortic balloon pump, at least we don't use, but some people, they do recommend. While this is a case I would like to show, this is a 48 years female, had a angina, and she was found to have troponin positive. Echo revealed some antiviral hypokinesis, ejection fraction 45%, and these are the, this is the anatomy. It is not a left main disease actually, but a very ostial LAD. I don't know how all of you would like to treat. There's another lesion in the LAD at a distance, which also needs tackling. Now there are two ways to do this patient. One is that you stent from the left main to the LAD. That is perhaps simpler, or other way that you do just the ostial LAD. I decided for the second. I thought there is space, and we dilated the LAD, and if you see there is a circumflex is okay, and this is the stent. That's the position of the stent. This is 3.5 into 40 millimeter R0 stent deployed at 11 atmospheres. Then we did the dilatation again, going inside the stent, and if you see that there is some dissection at the ostium of the circumflex, and crossed to the circumflex, did the balloon dilatation, but there was no, it didn't patch up. So I decided that it needs stenting from the left main to the circumflex, and the last picture is the position of the left main stent from the ostium to the circumflex. Yeah, this is just after kissing balloon, and that is the position of the stent into the circumflex. And this is recrossing into the LAD and then kissing balloon. This is 4 millimeter into the LAD and 3.5 into circumflex, and did kissing, and this is the final result, which was very satisfactory. Right. Well, my dear friends, I will finish here to say that left main stenting is really not that category we can't do these days. Selected patients with reasonable risk, left main stenting is very much possible, and I think everybody, every interventional cardiologist should understand how to do left main stenting. Thank you very much for your kind attention.
Thank you, Dr. Clare, for the comprehensive lecture, and may I invite Dr. Tanya to present a token of appreciation from Sri Lanka Heart Association. In the meantime, the President and the academic committee would like to extend their sincere thanks to Professor Asus Haman for accepting the lecture in a quite short period of time. Thank you. In the interest of the time, we don't have question time, so we'll move into the next lecture.
Thank you, sir. And next will be a lecture on women and heart disease. Chairpersons will be Dr. Jayantimala Jayawardena and Dr. Sanjeeva Rajapaksa. Lecture will be done by Dr. Sasanka Jayasuriya.
Yeah, we'll move on to the next lecture, which is going to be on a very important topic, the women and heart disease. And we have a special speaker today, Professor Sasanka Jayasuriya, who is an interventional cardiologist at Yale New Haven Hospital, and she is the director for the Center, Heart and Vascular Center for Women, the same hospital. So over to you, Sasanka.
Thank you very much, Sanjeeva. Good afternoon, everyone. It's my absolute honor to be here today, especially among some of my teachers and colleagues and friends. So let's speak about coronary artery disease in women and how it is different. I have no disclosures. I'd like to especially thank the Sri Lanka Heart Association and two of my batchmates from medical college, Dr. Mahika Senavikrama and Dr. Champa Kohomban, who are consultant community physicians at Sri Jayawardhanapura and Ruhuna, who actually helped me to tease out data from Sri Lanka relevant to this talk. So get into the topic. How's everyone holding up 1 hour after lunch? Let's make it quick and simple. So we all know that this elephant is not that elephant. And we know that this is a Sri Lankan dancer and that is a Sri Lankan dancer. But for the foreign faculty, just a quick explanation. On the right is the low country dance, and on the left is the low country dance, and on the right is the Candian dance, who you all saw on Friday. Very similar, but very different. This is a president, and that is a president. No introduction needed there. Coronary artery disease in men and coronary artery disease in women are very similar, yet very different, and that's what I'd like to talk about. So women and heart disease, yes to gender differences. 1 in 3 women die of coronary artery disease. Just in the US alone, 44 million women are affected by heart disease. More women have stroke in their lifetime than men do. And when women present with sudden cardiac death, 64% of them never have any other symptom before that. That is their presenting symptom. And 80% of heart disease in women can be prevented by managing risk factors. So one would say that is just data in the US. But this is just hot off the press. Just from 2 weeks ago in Circulation was this scientific statement looking at atherosclerotic cardiovascular disease in South Asians living in the United States. Why was this necessary? Because it was seen as a problem. What were these countries? This was us. What did it show? Very, very disappointing information. The light blue line is Asian Indian women over the age of 45, and this was the mortality ratio due to coronary artery disease. Across all age groups, 45, 65, 85, we had a much higher mortality ratio in comparison to the other Asians living in the United States. And women in the US from South Asia were also known to have a high awareness of coronary artery disease. We had excellent accessibility to healthcare. They had a much higher educational level, still had the highest risk. How are things in Sri Lanka? These are the commonest causes of premature death. In 2005, ischemic heart disease was the #1 cause. In 2016, we steadily held that #1 position with a 5% increase. But what was more concerning to me was that diabetes went from #6 to #3 with a staggering 40% increase. Let's look at the risk factor breakdown. This is the Demographic and Health Survey from Sri Lanka in 2016. Heart disease was very similar. The blue columns are males and the orange columns are females. As you can see, heart disease was very similar amongst males and females. Look at high blood pressure. There was an 80% increase in women in comparison to men. How about diabetes? 20% increase. How about dyslipidemia? There was a 50% increase in women. But do risk factors really affect women any differently? Let's look at that. This is coronary artery disease mortality in women with diabetes. The red line is women with no diabetes, and the black dashed line is women with diabetes. What do we see? There is a 5% increased rate of mortality when a woman has diabetes in comparison to men. But how about in comparison to men? They don't have such a high risk. Yes, a man with diabetes is doing poorer than a man who doesn't, but a woman does much worse if they have diabetes. How about coronary artery disease? This is data from the WISE study. The light blue line is premenopausal women, and the dark blue line is postmenopausal women. And if you see if their blood pressure was just 30 mercury millimeters higher, right there, their odds ratio of coronary artery disease was 2.5 times higher. So a young woman walking around with a blood pressure of 150 or 160 has a 2.5 times higher risk of coronary artery disease lifetime. How does metabolic syndrome equate? If a woman has metabolic syndrome, their risk of having coronary artery disease is similar to someone who has diabetes. That's not the same with men. They do not have such a high risk. So very, very concerning information here. Traditional risk factors are significantly higher in Sri Lankan women. The percentage of diabetes here increased by 40% in 10 years, and women have worse outcomes with these risk factors. So what do we think? When the Sri Lanka Demographic and Health Survey comes out from 2020 and beyond, I am concerned that these tall orange curves might actually mean that this curve would climb up over time. Traditional risk factors, we have an opportunity to learn from the data of South Asian women living in the US because they developed diabetes before the women in Sri Lanka, and now they have a high mortality rate. And there's an opportunity to notice the risk factor profile in Sri Lanka in the women population and intervene upon it now. So let's look at a case. 59-year-old lady comes to the hospital with severe nausea and abdominal pain for 6 hours. Past medical history, she says, I have none. Exam was pretty benign. You know, she looked very anxious and diaphoretic, but the rest of her exam was normal. Cardiac exam was normal, abdomen was soft, everything was fine. Some labs were ordered in the emergency department. The white count was up. AST was a little up. The rest of the belly panel, everything looked great. Electrolytes were normal. Finally, the troponin turned around, and the cutoff at our hospital was 0.04. Hers was 0.05. So this was an hour to 90 minutes later. The emergency physician goes back to see her. Looks much worse, more diaphoretic, looking really poorly. Now let's get an electrocardiogram. What do you think? Rip-roaring ST elevation. She probably didn't have ST elevation walking in the door, but during the time she was there, she got much, much worse. So the diagnosis here is anterolateral STEMI and Yentl syndrome. What's Yentl syndrome? Yentl was based on a short story where a woman had to disguise herself to go to religious school as a male so she could learn more. And with this, Bernadine Healy in 1991 in the New England Journal of Medicine described Yentl syndrome, where women are not taken seriously from a medical standpoint unless they present with symptoms like men do. How do men present with ACS? Everyone knows. They have chest pain, chest pressure, diaphoresis. When I was an intern at NHSL and I would be clerking patients on a casualty day, even the attendant in the hospital would knock on the door and say, Miss Mangitan, MI case ekak, because there will be someone who looks so sick and bad. But that's not the case with men, with women. In the US, the male patients tell me it's like an elephant sitting on their chest. But 11 to 35% of women can actually present with atypical symptoms. Nausea or vomiting, upper body discomfort, back pain, jaw pain, indigestion or dyspepsia. Dyspepsia is actually one of the commonest symptoms that women who don't have chest pain have. One of the hospitals that I care for is in Greenwich, Connecticut, which is one of the richest zip codes in the US. And there are very well-educated, high socioeconomic status ladies who over the weekend would be chewing on antacids and PPIs and show up on Monday with a completed infarct, just because the symptoms are not so significant. Women can feel dizzy, lightheaded, and have minimal symptoms. How are the troponins matching to women in comparison to men? Remember, this woman had a very mild troponin rise. It's been shown in multiple studies that if women were to have high sensitivity troponin, at least another 6% would be captured. So the take-home message is if a woman has symptoms that are concerning for chest pain or ACS, even if the troponin is negative, just be patient. Maybe the next one will be positive. So what's the solution to this? Awareness, awareness, and more awareness. In the US, the UK, and in other countries around the world, there is the Go Red program where women dress in red. They make a lot of noise about that. We try to educate doctors, nurses, physicians, the community. Everyone bands together to try and fight this because it truly is a problem. Let's talk about STEMI in women, just a few things. They present late. Women are traditional caregivers here and around the world. So you stay at home taking care of your children, your husband, your family, your neighbors while you're infarcting. They have less extensive ST changes usually, less utilization of PCI, increased bleeding risk with worse outcomes. So therefore, if you are a radial operator, always consider radial for a woman. PCI in a woman reduces the composite endpoint of death, MI, and repeat ACS 33% in comparison to a man if performed during a STEMI. And younger women with STEMI specifically have much worse outcomes. Our interventional group at Yale, we care for about 700 patients with STEMI a year and performing primary PCI. It's always very satisfying to do a STEMI to see how well a patient does, but my least favorite cases are young women who are really sick, because we know over time that the chances of doing poorly is high. So remember how this patient said, I have no medical problems. But here's what the data say. Have the risk factors ever been checked? Women undergo less testing and screening for cardiac risk factors than men do. I'm very pleased to see centers like this come up in Sri Lanka, but if we are to fight this problem, almost every woman has to be screened at one of these centers. They have to belong to these centers where they are followed in a long-term basis. The second question is, we talked about traditional. How about non-traditional risk factors? Nature's stress test. Pregnancy-related complications and relationship to cardiac disease in women has been very well studied. Preeclampsia, which we all know affects 3 to 5% of pregnancies. It's the leading cause of fetal and maternal morbidity and predicts the risk of future cardiovascular disease as well as diabetes. This is a meta-analysis looking at coronary heart disease after preeclampsia, and you see that the odds ratio of CHD is 2.3% in comparison to someone who does not have preeclampsia. If a woman who has preeclampsia, her relative risk of heart failure is 3.6 compared to someone who didn't. If someone had preeclampsia, their odds ratio of stroke was 1.8%. So preeclampsia itself in the longer term really poses a very bad prognosis for a woman with cardiovascular disease. How about gestational diabetes? The dark line on top is patients who did not have gestational, and the lower line in this Kaplan-Meier are patients who did have gestational diabetes. You see that there is a significant difference in event-free survival, even at 10 years. So if a woman had a child at 25 or 30, we are talking at 35 and 40 years, there is a significant separation in the curve if they had had gestational diabetes. Gestational diabetes also increases your lifetime risk of diabetes, hypertension, ischemic heart disease, but there was no change in stroke. How about the duration of pregnancy? If someone had a preterm baby, their risk of long-term coronary artery disease was significantly higher. And it was interesting, if it was a medically indicated delivery, that hazard ratio was much higher compared to a spontaneous preterm delivery. So in other words, anyone who has a preterm baby is at risk, but if it was a medically induced delivery due to preeclampsia or something like that, that risk was much higher. So women after childbirth, we should monitor them for resolution of gestational diabetes, resolution of pregnancy-induced hypertension and preeclampsia, educate women with premature or small for gestational babies regarding their risk, and encourage weight loss, as well as entrust the role of education to the obstetricians, doctors, and midwives caring for these patients. So when you all go back to your regional centers, partner with your obstetricians, talk to them about it, because you know that these are the people you'd be caring in the next 10 to 15 years. This is an example of one of the posters we have in our high-risk maternal fetal clinics, where we tell women, and we have a very high literacy rate, we can have things like this to also tell the women who are having kids in Sri Lanka. There are other female-specific medical conditions which increase the risk of cardiovascular disease. Women with SLE between the ages of 34 to 44 have a 50 times higher risk to have an MI as opposed to someone who doesn't. Polycystic ovarian disease poses a high risk. So is early menarche, early menopause, ovarian failure, and oophorectomy. Depression in women is much worse than depression in men from a coronary standpoint because we have a higher risk of coronary artery disease for some unclear reason. It's a tough place because when a woman's depressed and complaining of chest pain, you think it's a manifestation of the depression, but it may not be because their risk is high also. Breast cancer is also tricky because chemotherapy causes cardiotoxicity, as well as radiation can cause coronary artery disease and valvular disease. Radiation can be so significant that women who have left-sided radiation are at a much higher risk of CAD than those that have right-sided radiation as well. Let's look at another case. 39-year-old woman with a 3-month-old baby, history of hypertension, brought in by the emergency services with chest pain and dyspnea. En route in the ambulance, she has a VF arrest. She was successfully defibrillated with return of spontaneous circulation. This is her presenting EKG. Where do we go? Cath lab? Yeah. So we took her to the cath lab. Can we play these videos here? There we go. So the left side looks somewhat okay. The left anterior descending artery on the second picture looks a little funny, but overall not too bad. This is the right coronary artery here. And if you pay attention, you can see that there is a split in the right coronary artery. So what is the diagnosis here? This is spontaneous coronary artery dissection. Where you see the true lumen in picture A, in picture C, you see there's a small intimal tear, and blood creeps under that tear into the false lumen, compressing the true lumen and obstructing flow. This is a histologic picture. The first one is the true lumen is really compressed down with the false lumen being big. And the second picture, again, you can see the true lumen is compressed down and the false lumen is really big. So this is the IVUS image. This patient was very unstable. She was having short runs of VT, chest pain, and ongoing ST elevation. So we decided to take a look. And what you see here is that the true lumen, the guide wire is actually in the false lumen and the IVUS catheter is in the false lumen. And you could see the true lumen kind of squished around the 9 o'clock position there. Fortunately, just before the IVUS catheter comes into the guide catheter, we do enter the true lumen. So distally we are in the true lumen, proximally we are in the true lumen, in between we are in the false lumen. But as the patient was unstable, we decided to stent this. And the next IVUS showed that the stent was well opposed. There was no other problem at this time. STs got better, she felt much better, high fives all around, we were doing great. But 36 hours later, she had more chest pain. So we brought her back, this time through the groin. The right coronary artery looked okay, but in the interest of time, the left coronary artery had now dissected, the dissection had progressed. So at this time, we opted to medically manage her because it's not smart to put in stents when someone's having a dissection because you can start extending it and it can come back to the left vein ostium. So SCAD is seen 4% of all ACS cases, occurs overwhelmingly in women. 35% of women less than 50 might be having SCAD, mostly in the LAD. How do you treat it? If there's TIMI 2 to 3 flow and the patient is stable, leave it alone. If it's 0 to 1, try to stent. Try low pressure injections, ICT and IVUS, OCT and IVUS guidance is important. If it's a young woman, think SCAD. Consider angiography over thrombolysis, just because you can see that thrombolysis is not going to help this. We'll skip over this. This is another case, normal coronary arteries. We saw a great example of this during the hemodynamics lecture. Diagnosis Takasubo, again seen in women. So this was a 35-year-old woman with chest pain. That she was having random chest pain now and again. We brought her to the lab, tried to go through the radial artery. We always try to do that first. 1 minute into the case, we realized we were in trouble because the catheter wouldn't go further, it wouldn't come backwards. So with a lot of sedation and a lot more anesthesia, we were able to get the catheter out. Then through the groin, we did an angiogram. It looked beautiful, everything was fine. We were about to close the groin when she started having ST elevation, chest pain, pressure dropped to 60. The nurse pulls up the bench to do CPR. And we shot the right, and that's what it looked like on the right side. So the differential for this is we either embolize something down, either vessel dissected, or because she had significant spasm and this looked like spasm, we realized that was the case and gave her a lot of vasodilators, which helped to open the vessel. Syndrome X, microvascular disease, is another disease seen in patients with coronary artery, in women patients. Long term, although the epicardial coronary arteries are normal, they have very bad outcomes. So if there is someone who has typical angina and normal coronary arteries, treat them as if they do have coronary artery disease. Another disease in women is Minoka, sounds like a Sri Lankan name, but stands for myocardial infarction with normal coronary arteries. That's when there's undiagnosed plaque by angiography. So in conclusion, coronary disease is the #1 killer in women. Women in risk factors have much worse outcomes than men. In Sri Lanka, women have much higher percentage of diabetes, hypertension, and dyslipidemia. Does this mean it's an ominous future to women? Women of South Asian origin in the US have the highest mortality ratios, and are we heading there in Sri Lanka? We present with atypical symptoms. Pregnancy is a great opportunity to find these people. Other conditions that can mimic CAD are SCAD, Takotsubo, and microvascular disease, as well as Minoka. Having said that, CAD in women, is it the same? I say no. Do you say yes? This is my medical college. That is my school where I'm teaching now. That is my Twitter handle for all the trainees. If you don't have a Twitter account, open one now, because it's a great way to be engaged in what's going on in the rest of the world. And finally, my email for future collaboration or any other help I can offer. Thank you very much.
Thank you, Sasanka, for that eye-opening lecture for women and for men who look after them. And thank you for coming all the way and volunteering to give this lecture.
Yeah.
And we feel proud of you for having reached such heights in your specialty. Dr. Sanjeeva Rajapaksa will offer you a token of appreciation in behalf of the Sri Lanka Heart Association.
Thank you, Madam. Thank you, Chairpersons. We will now move on to the next lecture on dietary advices to patients with dyslipidemia and coronary artery disease by Professor Raman Puri. I invite Dr. Ajit Kularatne and Dr. Asel Anthony to chair the session.
After that shocking revelation regarding the ladies in our country, we would turn to the diet, how to manage all these issues. The lecture will be dietary advices to patients with dyslipidemia and coronary artery disease, presented by Professor Raman Puri. Over to you, Professor.
Thank you very much, and good afternoon, everybody. Dr. Mubarak, thank you very much for inviting me here and asking me to speak on a lecture which I never, spoke in my lifetime. This is the first time I'm speaking on dietary advice. So if there are some, lapses, please excuse me. Yesterday in the morning session, I discussed about what should we do for preventing coronary artery disease, and as she will agree to it, that we have to screen our population for risk factors as early as possible. And I really offered that it should be done at the time of college admission, because that is the time you can do things much easier. And if there is a disease, try to maintain the targets, which are very important for us. And the maximum advantage which you get is by lifestyle modification. If you follow these, I think we can prevent coronary artery disease, that too in our South Asia where it is an epidemic. The inter-heart study is a very important study because for the first time it has made to understand there are 9 modifiable risk factors, and if you control these risk factors, you can prevent 90% of first myocardial infarction. What else do you need? You have to look into these risk factors, and 4 of these risk factors are known to everyone, and another 5 risk factors are also a part of our life. And it is not only inter-heart study, even the inter-stroke study have shown that if you control 5 modifiable risk factors, hypertension, smoking, waist-hip ratio, diet and excessive alcohol intake, you can prevent 80% of strokes. So 90% of myocardial infarction and 88% of stroke can be controlled by controlling these risk factors. How diet contributes to increases the incidence of cardiovascular disease? This is through lipids. It is said that increased cholesterol intake or fat intake increases the level of serum cholesterol. And you all know that serum cholesterol has a direct relation with coronary artery disease. So this is one of the mechanisms by which diet contributes to increase CVD risk. And 7-country study was the first study to show this positive linear relationship between dietary cholesterol and coronary artery disease. And some of the meta-analysis of randomized controlled trials shows that lowering saturated fat and cholesterol can reduce LDL cholesterol by 10 to 15%. And for every 1% increase in intake of saturated fat, blood cholesterol increases by 2 milligram per deciliter. This is a very interesting study which was published. This is from the Japanese population. Some of the Japanese population were consuming 10% fat calories in the diet, and some population staying in Los Angeles was consuming 40% fat calories in the diet. And it was found that those who were consuming 10% had the least serum cholesterol level, and those who were having 40% and more were having the maximum serum cholesterol level. Again, highlighting the importance of level of cholesterol with dietary fat intake. There are a few regional diets which are associated with low coronary artery disease, CHD, and you all know Japanese, they have very low incidence of coronary artery disease, and Eskimos also have very low incidence of heart disease. And if you go into hunter-gatherer tribes, these are the tribes who still follows long back tradition of hunting animals, and they take a lot of animal proteins and fat, and their food is also plant-based food. They have very low level of LDL cholesterol. They have about 70 milligram of LDL cholesterol. These tribes are still in Central America and some part of Australia, and they do not suffer from heart problem, and despite that they have other comorbidities. So I think that diet plays a very important role, and we'll discuss today that what should be our proper diet. This is diet of average Sri Lankan population. There is the 72% of calories comes from carbohydrate, 20% calories come from fat, and about 10% calories comes from protein. Is it a good diet? I think, will you answer? Is it a good diet? Answer is, I'll give you the answer. Now, this is a study which has been published in 2017 in Lancet article. This is 135,000 population food frequency questionnaire survey, and in which and it was initially in 18 countries, and it's almost 14 years now. It has now extended to more than 200 countries with 200,000 patients. What does it show? That on average, Asian consume more carbohydrate as compared to non-Asian, number one. Second, if we take the lowest quintile, means the person who is consuming the lowest carbohydrate, if we increase the carbohydrate intake, you can see that there is increase. Is there a pointer there? There is increase in total mortality. Means as the percentage carbohydrate in the diet increases, there is increase in mortality, and cutoff is somewhere around 55 to 60%. If your percent energy from carbohydrate is more than 60% or 55%, there is increase in mortality. And there is increase in not only the total mortality, there is increase in cardiovascular disease also in patients who has those who consume more carbohydrate. I'm talking of 55 to 60%, and average Sri Lankan takes 70 plus carbohydrate calories out of the total calories. So that is something which we have to understand, that WHO said go up to 75%, you can replace carbohydrate for fat, but that is absolutely not true. We should not increase carbohydrate in lieu of you restricting the fat. And this is true because ApoB, ApoA ratio was done in this survey, and it was found that as your percent energy from carbohydrate goes up, the ApoB, ApoA ratio also goes up. So this means, as you know, that inter-heart study, ApoB, ApoA ratio was very important predictor of ischemic heart disease. So I think that really gives you that there is a strong correlation of increase in ApoB, ApoA with increase in carbohydrate diet, and that eventually leads to coronary artery disease. Now, it is not only the carbohydrate intake which is important, it is even the type of carbohydrate which you consume is very important. So the carbohydrate which is solid is better than what is liquid. So carbohydrate with increased fiber diet is important, and whole grain is important than refined grain, because all these things results into the glycemic index, and it is better to have low glycemic index as compared to high glycemic index. So what should we do? We should avoid refined sugar, sugar-sweetened beverages, refined grains, white bread, white rice, potatoes, and sweets. I think on way from airport to my hotel, I was asking the driver that what all do you eat? So he gave me a very clear picture of dietary habit of Sri Lanka. He says we eat rice, coconut milk, consume oil, and I asked him how much fruit you take. He says 2 fruit in a week's time. How many vegetables you take? I take average of 250 grams of vegetable every day. So I inquired about him about the dietary habits. So rice probably is one of the reasons which Sri Lankan has a lot of rice in their diet, might be contributing to increase in prevalence of coronary artery disease. Still, it remains #1 as compared to what it used to be a decade before. Whereas oats, whole grain cereals, brown bread, corn, and brown rice are a better carbohydrate. And if we can keep ratio of carbohydrate to dietary fat less than 10, it will be a better option. Now coming to fat, all of us are scared of fat, that we should not take fat, saturated fat. This study gave us a very different picture. It says that if you increase fat from lowest quintile to the highest values, it reduces total mortality. Not only in total fat, even the saturated fat, polyunsaturated fat, and monounsaturated fat, increase consumption of these, but in a moderate amount, not in extremely high values I am talking about, in a moderate quantity. There is a benefit in mortality, reduction in mortality, and there is benefit in reduction in cardiovascular disease. And Asians consumes less fat as compared to non-Asians. Now, saturated fat does increases LDL cholesterol level. As shown in this study also, but the rise is very marginal, 0.1 millimole. But even rise is rise. It should at least not decrease the mortality. It should at least have some impact. Then why the mortality has come down? Because ApoB to ApoA ratio in saturated fat doesn't increases. You can see it's a downward trend, may not be p-value, may not be significant as compared to carbohydrate where it goes up and p-value is 0.001. And if you look at monounsaturated fat and polyunsaturated fat, there is a significant reduction of ApoB to ApoA ratio with monounsaturated fat as compared to polyunsaturated, which is fairly almost a horizontal or slight decline in the value. Now, this is an overall picture of all the total fat, saturated fat, unsaturated, polyunsaturated, and monounsaturated. You can see that it is only monounsaturated fat which shows a constant decline with increased intake, where rest of the fat, it's almost a plateau. So this means all fat means saturated, polyunsaturated and saturated fat has a neutral effect after their intake, means rather they do not increase the cardiovascular mortal disease, neither it decreases, whereas monounsaturated fat has a positive trend, means it decreases the incidence of cardiovascular disease. This is nutshell. Increase in carbohydrate results into increased mortality, results into increased cardiovascular disease, whereas intake of fat, there is a decline. But remember, what I'm talking of increased fat is a moderate amount of fat consumption, not extreme high and rather extreme low. Now, if we try to divide saturated fat from different sources, like from the dairy products, from the red meat and from the white meat, there is not much difference. It doesn't change much. So the very, very well thought that you should not take milk with, and if you want to take milk, you take 1 or 2% fat milk is no more true at all. So you can enjoy milk of your choice. If you want to have a whole cream milk, please do enjoy that. But remember one thing, extreme of everything is bad. Too low a thyroid hormone causes hypothyroidism, and high causes hyperthyroidism. Keep everything in a physiological level. Don't go to the extreme. So this means you can have cheese, you can have butter, you can have red meat, you can have white meat, you can take anything of your choice, but with a not lot of serving, restricted serving of 2 to 3 per week. Trans fat, no. We Indians take a lot of trans fat. All our dinner and lunch is full of oil, and pakoras, samosas, we all enjoy. And given me opportunity, I'll also take. So this is one of the factors for our increased coronary artery disease, because it's well known that trans fat increases LDL and decreases HDL. Cholesterol, so far, no relaxation in cholesterol intake. It should be restricted to 200 milligram to 300 milligram per day. Now, since vegetable oil constitutes the most important dietary component, we should talk about this, because it's important to understand what should be an ideal coconut cooking oil. It should be low in saturated fat, high in monounsaturated and polyunsaturated fatty acids. Omega-6 to omega-3 ratio should be less than 10:1. And there should not be any trans fat. It should be stable at high temperature, and it should be non-refined. It should be virgin coconut oils we should use. These are the list of oils. I'm not going because I'm seeing the watches. These are the list of different oil which shows various components. And now combination of oils are also very important. And all these things are, we have already published in our article, which was in JAPI, which has given all the details which I'm talking about. And now coming to the coconut oil, is the oil which is very, Sri Lanka is fond of, and even South India is also fond of. It's something, controversial in a sense that it is a saturated fat, and saturated fat to an extent of 90% saturation. And still, there is a debate whether it should be used or not. One of the positive points with coconut oil is that it increases LDL and it increases HDL also. The ratio of LDL to HDL is almost kept normal, and it's a medium chain fatty acid which has a neutral effect towards cardiovascular disease, so it doesn't cause cardiovascular disease. And now there is a possibility of a virgin coconut oil. In animal study, it has shown that it reduces LDL cholesterol and HDL cholesterol. One of the study of coconut milk I went through because I had discussion with the prime author yesterday, and it has also shown that there is a decrease in LDL cholesterol and increase in HDL cholesterol. And it sounds correct, because when you make coconut oil, you don't heat coconut, so there is no chances of changing or losing flavonoids and phytochemicals which are antioxidant and anti-inflammatory. So you preserve those important chemicals. So that is, I think, probably it may be a correct statement, but of course it requires a randomized controlled trial to find out whether it does increases LDL and decreases LDL and increases HDL. Now, these are the few oils which have an evidence-based, olive oil is the best, followed by mustard oil and canola oil. And regarding vegetables, fruits and legumes, 3 to 4 serving daily is said to reduce cardiovascular mortality. And then talking about exercise, we all know that exercise increases HDL cholesterol, increases arrhythmia threshold, decreases non-HDL cholesterol and triglyceride, and it reduces level of PCSK9. This is what is the requirement, at least 150 minutes of moderate physical exercise every day. Every week, or at least 75 minutes of vigorous physical activity. You can do in combination or individually, but normally what I advise to my patient is 5-kilometer brisk walk in 40 to 45 minutes every day is, what I have been practicing for the last many years, and I do myself also. This is, it's easy for everyone to understand that. And regarding yoga, I could find that there has been a recent publication in European Journal of Cardiology where yoga was compared with non-exercise, and it was found that it reduces BMI, reduces blood pressure, reduces it reduces cholesterol, it reduces triglyceride, but it has no effect on blood sugar or glycosylated hemoglobin. And the extra advantage of yoga is that many of these persons they stopped smoking because they came to know that, smoking is bad, so that is an added advantage of yoga. These are few diets. This is Mediterranean diet, we all know. This shows that there was 30% reduction in myocardial infarction, stroke, and as compared to low-fat diet, there was no benefit. And there is an Indo-Mediterranean diet also. In place of olive oil, mustard oil or soybean oil was used. And this is our recommendation of Lipid Association also recommended the diet we should follow. And now, in conclusion, I'll say that carbohydrate over 50 to 60% of total calories is harmful. Choose fiber-rich whole grain for most grain serving because these are low glycemic index food. Avoid white rice, white bread, potatoes, refined sugar. And if you want to take sugar, it should be less than 10% of the total calories, and sugar-sweetened beverages. Saturated fats are not harmful in the usual range consumed by most people. It should be in moderate amount. Monounsaturated fatty acid is protective. Polyunsaturated fatty acid is neutral. We should take vegetable, fruits and legumes in plenty because they are also neutral towards cardiovascular disease. We should replace high calories food with fruit and vegetable. Olive, mustard, canola and non-refined oils are preferred. Virgin coconut oil preferred over refined copra oil. And poultry and fish falls in neutral category. Milk should be of your choice. No more, restriction in not taking whole cream milk. And I think, but don't forget that you should maintain your BMI. You should take care of your blood pressure. You should keep normal glucose level. No to tobacco, alcohol in moderation, regular physical exercise, yoga and meditation. And most important thing is keep your LDL cholesterol to the targets. And if you are able to keep your LDL cholesterol to the target, if you enjoy some component more than what is been recommended, I think that will not matter much. And that only you can do when you screen yourself, your family member, your all patients for all risk factors for coronary artery disease. Thank you very much.
Thank you very much, Professor Puri. And I must also thank you for accepting our invitation and to deliver
Thank you, sir. Thank you, chairpersons. We shall recommence after a short break for refreshments. Ladies and gentlemen,